Thanks very much, and thanks for the invitation to be here. I really enjoyed those 2 previous lectures. I just want to take a very quick poll. How many of you in the room are basic moral philosophers? Okay, and how many are healthcare providers or training to be healthcare providers? Okay, so most of you. Okay, so the last 2 lectures were incredibly interesting, and I think the juxtaposition of the views was really informative. I'm going to talk about sort of what comes next, what this all means for healthcare providers. So hopefully that'll start to tie together some of these ideas that we've been discussing. So what I'm going to do is provide a bit of an update, and John has already done a good job on this, on the current Canadian legal landscape on end-of-life care and assisted dying. And then I'm going to help to clarify, this has already come up a couple of times, but clarify some of the work that the CMA has been doing in this area and where we sort of are at present. And then talk about some of the next steps, both in terms of what John alluded to around legislation and regulations, as well as what's happening with the process right now, and hopefully bring you up to date. This is, to say the least, very rapidly evolving, and I always check the newswire shortly before I give a presentation, because on many occasions I've had to change my talk or change my slides right before, and in fact, as always, this week there have been some developments as well. This is a headline from Canada's official medical journal, the Globe and Mail, and as you can see, this is from last June. It says Quebec is the first province to adopt right to die legislation, and this was one of those situations where I was just about to give a talk to the Ottawa Academy of Medicine at 6 o'clock, and at 4 o'clock Quebec voted on Bill 52, which then became law. And I'm going to unpack this a little bit and talk about how it sort of does and doesn't impact on the current situation with the Carter legislation, and what this means as well for the physicians of Quebec. So throughout this, I'm going to try and sort of use that physician, that healthcare provider lens to talk about what all this all means. And I'm going to agree with some things that John said and some things that Margot said, and 100% of the things that I say I'm going to agree with as well. And then later on this February, the Supreme Court rules Canadians have right to doctor-assisted suicide, which was, to say the least, a monumental decision. John already talked a little bit about Sue Rodriguez. Here's Sue, and Sven Robinson, her supporter from the NDP party. And when I do, like Margot, I spend a lot of time with the medical students at the University of Ottawa, and I often ask them, I try and give them a bit of a history lesson, and I ask them who this is, and they look at me blankly because they're all like 12 years old and they have no idea what happened back in 1993. But we've already talked about some of the parallels and some of the, the changes that happened between now and then. One of the things, the interesting things that I don't think surfaced that we found fascinating was the fact that there was only one justice who sat on both cases, and she happens to be the Chief Justice of the Supreme Court now, Beverly McLaughlin. She was the only justice that ruled on both cases, and she was actually in the dissenting minority in the Rodriguez case. So she was one of the 4 that voted in favor of a change in law back then. And so we had some of these little sort of hints already moving into this case. And the Carter case, as we've already heard, was a constitutional challenge of the Criminal Code section making physician-assisted dying illegal in Canada, brought forward, as John says, by the BC Civil Liberties Association and a group of individuals, including Lee Carter and Hollis Johnson. And we've already heard that they traveled to Switzerland. Now, Switzerland is, as you know, one of the few jurisdictions that doesn't have a residential requirement, and so you can actually avail yourself of assisted dying quite quickly there. One of the relevant facts in this case is that Kay Carter, after whom the case was named, actually didn't have a terminal condition. So Kay had something called cervical spinal stenosis, which is a degenerative condition of the spine. That's actually my field of medicine. I still practice medicine a day a week. I look after patients with spinal cord injuries. And so basically she had a lot of pain and mobility limitations and problems with bowel and bladder control that was really impinging on her enjoyment and quality of life. And so she decided preemptively to go to Switzerland and avail herself of assisted dying. And her family came back and said, this should really be a charter right in Canada. It doesn't seem to make sense that we would have to spend thousands and thousands of dollars and travel across the world and then essentially have our mother die in a place very far away from her loved ones, when the whole point of assisted dying really is to A, avoid suffering, but B, be surrounded by your family and loved ones when you do die. And it's interesting to note as well that actually Canada is about 7th or 8th in terms of the countries, the prevalence of going to Switzerland and availing oneself of assisted suicide. So it's actually a pretty common action that people in Canada take, but we don't hear very much about it in the press. And Gloria Taylor, as you know, really became the face of this, and like Sue Rodriguez before her, suffered from ALS. So we've already heard about the decision by Madame Justice Lynn Smith, and she then gave Parliament a year to draft legislation, and also granted Gloria a constitutional exemption during that period, and Ms. Taylor did die a short time later. And then the BC Court of Appeals, we've already heard, overturned that, and the Supreme Court of Canada, to no one's surprise, agreed to hear the case. And this took place about a year ago on October 15th, 2014. And the CMA appeared as what's called a friend of the court. And this is sort of an interesting fact, because we were the only friend of the court, actually. And what the friend of the court means is that you're not arguing for or against a change in the legislation. You're not appealing for or against the appellants. You're basically there to present a unique set of facts or unique information that might be helpful to the court in arriving at its decision. And so we appeared just before lunch, actually, after the appellants had made their submission and before the government and the other opposition had made their decisions. How many of you have been to the Supreme Court? Yeah, so a few. So, so this is the, it's a really interesting place. This is the rotunda. So when you enter in through the main doors, this is where you end up. And as you can see, it's this incredibly, you know, sort of beautiful multi-story entrance with marble and all these, you know, inlaid designs on the floor. And then up here, you go up these multi-level staircases up to the door that takes you into the court itself. And here it is, this little itty-bitty room. And here's where the justices sit. And here's where the lawyers sit, and here's where members of the public sit. So there's not a whole lot of space for members of the public. So as one of the interveners, we had external legal counsel who was representing us. Turns out when you go to the Supreme Court, the lawyers line up at your door to represent you for free because they all want the exposure and to be part of this process. So we had actually our pick of several really excellent law firms. But you only get 2 tickets. So your lawyers go, and then you get 2 tickets, and then anyone else who wants to go has to line up. So we gave our 2 tickets to our president and president-elect, and then myself and our chief internal legal counsel lined up in the pouring rain at 5 a.m. that morning. No one talks about how hard it was raining on that day, but I'm here to tell you, and John will back me up, it really was. So we did get in, and we were very glad, because it really did feel like, you know, regardless of your views on the matter, it felt very historical, and certainly a number of commentators have said that it may be the most important decision this court ever renders, not just up until now, but in history, because it really does have the potential to impact every single Canadian. Every one of us, believe it or not, is going to die. And you know, many of the court's decisions don't impact Canadians, you know, to nearly the same extent as this one. And we talked to commentators afterwards and some of the clerks, and they said yes, it was just different. There was a different feel that day. People recognized the importance of this, and it was a real honor to have been a part of that. So here were some of the key CMA points that we wanted to make. So we made apparent the fact that our current policy states that the CMA will support members on both sides of this issue. And I'm going to talk about how we arrived at this point. We also made it very clear that the profession, like the public, is divided. And I just want to say something briefly, because we've heard a little bit about polls, and I couldn't agree more with Margot that the public opinion polls have really been skewed. And I believe there's probably a majority of Canadians who would support the availability of legalized assisted dying, but it's nowhere near the 70 to 90% that we see quoted, or that you know, organizations like Dying with Dignity like to quote. And when we unpack these polls, and we've done this in Quebec and elsewhere, and we ask people, do you support euthanasia? And you know, maybe 80 to 90% of them say yes. And then we say, well, do you know that's actually injecting a lethal substance intended to cause the patient's death? It's not unplugging a ventilator. and the percentage goes way down. So there is still a lack of understanding, not just in the public, but frankly, I'm embarrassed to say, in the healthcare professions as well. And they did, again, it came out in the Canadian Journal of Family Medicine last year, earlier this year actually, where they polled healthcare providers in Quebec, of all places, who should know, doctors and nurses, and their level of understanding of the terminology was, woefully inadequate. So there's still not a real good grasp on exactly sort of what the level of support is. Now, when we polled our profession, we spent half of the sort of survey was making sure they understood the questions, and then actually asking questions to make sure they understood the questions. And so we felt pretty confident that our information was correct. And basically what we found is that support has grown over time within the medical profession, but not in leaps and bounds. It's grown very slightly, and I think that's partly what we saw is that that's a transition of the folks who indicated a number of years ago they were undecided to being in support of the change in legislation, but the percent of physicians who said they would participate has not changed significantly, and it's around 30%, depending on exactly what you ask. Now, that level goes down if we're talking about euthanasia versus assisted dying. So I want to make clear that physicians see a very practical distinction between the act of administering the substance themselves versus providing a prescription. So without getting into the moral distinction between these activities, healthcare providers see a very real practical distinction. And it goes way down when you start to talk about assisted dying for non-terminal conditions. I'm going to talk about that as well. What I think is that somewhere between 20 to 30% of the profession will participate in these activities. So a real minority, and yet when we look at that further in terms of absolute numbers, we're actually talking about tens of thousands of physicians. So it's not an insignificant number in terms of real numbers. We also told the court that there are some important practical considerations to be considered. And I think these are getting more and more attention as we get closer to the February the 6th deadline. So for example, things like capacity assessments. So I'm going to talk a little bit about the work the CMA has done. One of the things that we did is we sent me across the country last year a lot, and I met with a whole bunch of physicians where they lived and just talked about these things. This was before the Carter decision came down. And there was a psychiatrist in New Brunswick who said, you know what, I spend all day doing capacity assessments. I do nothing but capacity assessments. Imagine what's going to happen if this becomes legalized. All of my colleagues are going to send me all of their patients that ask to be put to death. Even if they don't have to, they're going to do it anyway because it's literally a life or death situation, and they're going to want to make sure that they have a second opinion. He said, I have no more capacity to do capacity assessments. And we had never even considered that possibility, that this could be an overload on our colleagues in psychiatry. And Margot's already alluded to this issue of technical expertise, and this is not a small point either. This is the first new, call it what you will, medical intervention, at least intervention, that Canadian physicians have been asked to undertake in centuries, if not millennia. No one in Canada, as far as I know, has ever trained in assisted dying. We've got a whole cohort of physicians who need to understand what's involved here. And Quebec has come out with their guidelines, and Margot went through some of those. I had a palliative care physician come up to me in Vancouver and say, look, not to be flip about it, people are really hard to kill. And if you don't know what you're doing, it can go very badly. And Margot alluded to the botched executions in the US. Those are horrifying. Physicians look at that and see these patients, or these, condemned prisoners, who live hours after their attempted executions in agony and suffering. That's clearly not the type of scenario that we want to have happen in anyone's imagination in Canada. So technical expertise is not a small issue. And just as an aside, you guys remember Jack Kevorkian? So he was Dr. Death down in the US, and he used to travel around in a van and kill basically anyone who asked him to. And it was really horrifying for anybody. And his assistant apparently is still alive and somehow got my name and email address and emailed me Jack's recipe. And so I had a hot shower and scrubbed myself all over. And then I just put that in a file, and I said, okay, if I ever need it, I have Jack Kevorkian's recipe. And I hope to God never to need it. So these are really important practical considerations for Canadian doctors who are basically saying, what the hell am I going to do when February 6th comes and that patient is at my door and I don't know what to tell them? right? This is all new for us. We also, and I cannot overemphasize this fact enough, end-of-life discussions between physicians and their patients need to be supported and become a part of routine medical practice. And if there's a silver lining in all of this for the medical profession, it may be that this has brought discussions about death and dying a little bit more to the forefront and made Canadian physicians as a whole a little bit more comfortable with having those. This is, and I am constantly struck by the irony of this, I spend 99% of my time now talking about an intervention that in all likelihood will impact 1% or less of Canadian patients. And yet, you know, we spend 1% of our time talking about an intervention that potentially could benefit everyone except those who walk in front of a bus, right? Almost all of us could benefit from high quality palliative care interventions. Depending on how you parse the statistics, only about 20 or 30% of Canadians have access to good quality palliative care. And as I already told you, surprisingly, we're all going to die. If I told you today that only 20 to 30% of patients have access to, say, renal dialysis, there'd be riots in the street. And yet very few of us are ever going to need access to renal dialysis. And yet somehow we as a society have completely failed when it comes to providing access to palliative care. And I can't, for the life of me, wrap my mind around this. So I just want to really emphasize the fact that this is something that the CMA in medicine takes very seriously. We've been working extremely hard to try and get a national palliative and end-of-life strategy in place immediately. Now, I'm a little bit more optimistic these days. This fell completely on deaf ears with the last government, who really, you know, their stance was really health is a provincial matter, which of course it is, but they wanted nothing to do with it. So there was no talk about national strategies. I mean, they voted down a national dementia strategy, for crying out loud. And so they really didn't want to talk about this. Now, in the remit letters to the new ministers, Trudeau actually makes reference to Jane Philpott about one of her priorities being a national palliative and end-of-life care strategy. So we're sort of cautiously optimistic that we might see some action on this file. But I would just encourage you never to sort of think about assisted dying in isolation. This is all part of a much, much bigger picture when it comes to the need for a lot better and a lot more coherence around end-of-life care writ large. And we as a profession need to do a much better job when it comes to this. So the Supreme Court ruling came down on February the 6th, 2015, and this was actually sort of a fascinating day and a really interesting way that they did it. So for those of you who follow government closely, you'll know that when they release the budget, they have what's called a budget lockdown, right? So what I do is I take the person on my staff that has really been on my nerves for the last couple of weeks, and I send them to the budget lockdown because it's just like purgatory. And they put them in a room, and they give them the budget, and they take away their cell phones and their computers, and they basically give them an hour with the budget to read it, and then they can come out and report on what was in there. And the court actually decided to do the same thing with this decision, and no one that I talked to could remember this ever having happened before. And so they invited the appellants and the interveners and the government and members of the press to come down and meet and get a copy of the decision in advance. So we sent our chief internal legal counsel, and we all sat around a little teleconference unit at the CMA, basically waiting for her to call in while we sort of refreshed our computers and waited to see what would happen. And she went in and got the decision at 9, and at 10 o'clock they opened the doors and let everyone out to let people know what had happened. And as you know, the court held that the appeal should be allowed, and that the two sections of the criminal code prohibiting euthanasia and assisted dying unjustifiably infringe primarily Section 7 of the Canadian Charter of Rights and Freedoms. And I want to spend a little bit of time on unpacking some of the language from a clinical perspective, because this is basically, if you're a doctor in Canada, this is basically what the Supreme Court has given you to go by when it comes to figuring out what to do when a patient asks this. So they say that the provisions of the criminal code are of no force or effect to the extent that they prohibit physician-assisted death for a competent adult person. So we heard earlier, and I agree with this interpretation, that competent means competent at the time of the request as well as competent at the time of the intervention. But I can tell you, I go to symposia. I was at a meeting Tuesday night speaking to the Medical Legal Society of Canada, and a couple of very prominent lawyers who have been involved in drafting previous legislation around consent and capacity said they read the decision differently, and in fact they think that it could allow for advanced directives or substitute decision makers. And you know, we didn't read it that way, and the legal opinions we've had since have not said that, but there is this view that some people have that they would like to see that in law. So adult people, there's no federal statute that defines what an adult person is. So as we've heard, in healthcare, generally what it is basically a sliding scale based on the maturity of that individual as well as the type of decision being made. So, but physicians are going to be faced with this situation where unless we have clarity, we're not sure really what adult means. So this person has to clearly consent to the termination of life, and then they have to have a grievous and irremediable medical condition. So I've spoken to probably tens of thousands of physicians on this issue, and every time I speak to them I say, how many of you in this room have ever told one of your patients, Mrs. Jones, I have terrible news. Your condition is grievous. And 2 people have raised their hands, and I'm pretty sure they were both lying. No one ever says grievous, right? Like that's from 15th century England. They probably said grievous a lot back then. It's probably bad, is not good for sure, so we know that. But that's meaningless to physicians to say, I have to have a patient whose condition is grievous. I don't know what that means. And grievous based on whose interpretation? I mean, the patient could say, honestly, and I'm not being flip, they could say, I stubbed my toe and it really hurts, it's grievous. And I might say, well, it's not. And they say, yeah, but the Supreme Court just says, I have to, we don't know how to interpret that. And irremediable, we probably have a better sense. So irremediable sort of means, you know, we can't cure it, we can't make it right. But again, based on whose interpretation? So how many rounds of chemo does a cancer patient have to try before their condition is deemed irremediable? How many antidepressants does someone with a depressive illness have to try before it's irremediable? We don't know. We have no idea. So this is basically what the Supreme Court has given us in terms of clinical criteria. Couldn't possibly be less useful. So these things can include an illness, a disease, or a disability that causes enduring suffering that's intolerable to the individual in the circumstances of his or her condition. And we all certainly recognize that suffering is completely subjective, right? There's just no way around that. What's one person's suffering, you know, is another person's easily tolerable situation. So that's really in the eye of the beholder. So we were sitting around on February 6th looking at this, and someone said, you know, Jeff, wouldn't this apply to every single one of your patients? I looked at this and I thought, well, I look after adult spinal cord injured patients, so they're competent adult people who could clearly consent by any stretch of the imagination. They have a grievous condition, it's irremediable, none of them will ever be cured. It's a disability. Many of them have enduring suffering. They have chronic neuropathic pain, they have neurogenic bowel and bladder, they can't walk, for crying out loud, right? For a lot of people that's pretty bad suffering. And I realized, yes, every single one of my patients would qualify for assisted dying under these terms. And I haven't had a good night's sleep since then. So I cannot overemphasize, and this is where I will again agree with Margot, on the impact of this change on the medical profession. I cannot overstate the monumental sea change that this means for doctors and their patients. It could not be more momentous and more monumental. And the profession is really struggling with this. So the declaration of invalidity was suspended for 12 months, so we're coming up to February the 6th of 2016, right? And we have heard rumors, and I heard them again today, that the Liberal government will ask for a 6-month extension. I've heard that the court will probably grant it. Certainly a greater chance of that than if it were still the Conservative government, because they certainly have the argument to say, look, we've kind of been saddled with this and we're starting from scratch to some extent. So we're waiting to hear over the next few days what happens with that. And it's always nice when you spend a few months drafting, you know, your submission to the Supreme Court to see it quoted in the court's decision. And so among other things, what they said was that the CMA's current policy states that it supports the right of all physicians within the bounds of the law to follow their conscience in deciding whether or not to provide aid in dying. And it seeks to see that policy reflected in any scheme that may be put forward. And then they said, and we've heard this, in our view, nothing would compel physicians to provide assistance in dying. It simply renders the criminal prohibition invalid. What follows is in the hands of physicians' colleges, Parliament, and the provincial legislators. And so that's exactly where we are at the moment, in the hands of these folks and others. So I want to touch on some of the unanswered questions here, and here's a huge one from the standpoint of the healthcare professionals. The whole issue of terminal illness. So there's no reference to this in the ruling. There's a lot of discussion before the court. Clearly it wasn't an unintentional omission. Clearly it's intended to apply not just to people with a life-limiting illness, but to those who have conditions other than those that would be expected to be terminal. As expected, there's nothing in there about oversight and reporting mechanisms, nor anything for what the process would be for requesting this and determining patient qualifications. There is this reference to conscientious objection, but one of the big issues right now in the medical profession, and I can tell you in the nursing profession as well, is whether or not someone who conscientiously objects has an obligation to then refer that person to someone else who will provide that service. And that's extremely contentious right now within the healthcare professions. And I can elaborate on that if you want. I'll just say that currently the only jurisdiction in the entire world that has a policy requiring mandatory referral is the College of Physicians and Surgeons of Ontario. And they haven't yet applied it to assisted dying, although they probably will. The 3 or 4 provinces, so we all have a College of Physicians and Surgeons in our province. So the College of Physicians and Surgeons of British Columbia regulates the activities of physicians here. And so all these provinces are working on policies that, among other things, will address this issue of conscientious objection. All of the draft ones that I've seen don't support mandatory referral. The only other thing I'll say about that is that the whole issue there is around access, essentially. So what they're saying is, we want to make sure that if patients have a right to this, based on the Supreme Court decision, they won't be denied that right because they can't find someone to provide it. We don't see access as being a concern. I've already said there's tens of thousands of physicians that are willing to provide this. We're pretty convinced that there's other mechanisms we can use that wouldn't cause physicians to breach their own moral views and have to refer to someone else. So again, happy to discuss that further if you want to. The final issue, and it's an important one, is this just physicians or is it other healthcare professionals as well? So we actually got a constitutional lawyer to review the decision, and they were very clear this applies just to physicians. So it's not a situation where a nurse can do these activities or a pharmacist or another member of the healthcare team. It very clearly just applies to physicians. And I was in Toronto a few months ago, and I was part of a panel discussion, and one of the people on the panel was a good friend and colleague of mine, Kerry Bowman from Toronto, who's also a social worker. And he said something about, why should it just be doctors? Why shouldn't it be other healthcare professionals? And the audience said, yay, boo doctors, yay, other healthcare professionals. And I said, you guys don't get it. I'm not up here telling you we won, doctors won at the Supreme Court. Now we get to do away with Mrs. Smith, who's been on our nerves for months. That's not at all the case. We are being dragged kicking and screaming into this. And even the colleagues that I have who have said, look, and who are very vocal in their support, who are very compassionate and caring and dedicated, and said, I'm glad the Supreme Court decided this. I argued for it. I'm a card-carrying member of Dying with Dignity. Even those doctors are saying, I'm already in counseling because of the impact this is going to have on me. I have preemptive PTSD. I lose sleep every night thinking about the impact that this is going to have on me, my family, and my patients. This is a really big deal for doctors. Even those who are very, very compassionate and want to see this enshrined in law, they recognize the impact this will have on them as well. So even though, yes, it's just physicians, it's not something we ever asked for or volunteered for. And yet, we are ready, when February 6th comes, to provide this. And I would, to Margot's point, I would say, even though it's not something we asked for, I think we recognize that we have a sufficient number of colleagues that will step forward And really, it is probably where it should live. And the reason I say that is because of this whole issue that I mentioned before about the broad spectrum of treatment at the end of life. And so I don't want to see this marginalized to some sort of a technical capacity where sort of when all else fails or whatever, you know, we shuffle the patient off to the euthanologist. I want to see this be part of the whole end-of-life care discussion where we talk about palliative and spiritual care, and we talk about family relationships, and we talk about other options that are available, and this is one of a series of options. And if you just delegate it to a technician, you don't get to have that same kind of intervention and that same kind of relationship with the patient. So even though I tell you the medical profession is coming to this reluctantly, I think we accept that this is sort of our lot and that this is probably where it should live. I'm going to talk a little bit about, as long as my battery doesn't run out, I'm going to talk a little bit about the situation in Quebec. And Margot's made reference to that and probably understands the situation there much better than I do. So Bill 52 is an act respecting end-of-life care. And it contains legislation mandating that every institution offer end-of-life care. Now, interestingly, there is a carve-out, and I've had this opinion affirmed by others, that basically says that palliative care institutions don't have to provide this, which is why I was very surprised when there was such a reaction when a number of palliative care, well, basically all palliative care facilities said that they wouldn't provide it. End-of-life care, though, does include, according to this definition, palliative care, palliative and terminal sedation, as well as medical aid in dying. Now, I think it's very positive that the Act basically says every patient in Quebec has to have access to palliative care, and yet we haven't seen the resources put into that would actually make that a reality. There have been some increase, but certainly not enough to provide it for everyone. And what they mean by medical aid in dying is clearly euthanasia. So this is when administration by a physician of medication or substances at the patient's request to relieve their suffering by hastening death. So that's not assisted dying, that's euthanasia. And here are the criteria. So the person has to be of full age, which in Quebec is 18, capable of giving consent, and an insured person, which means a resident of the province. They have to have an incurable serious illness and be at the end of their life. So here we have a qualification in the Quebec legislation that does not exist in the Supreme Court decision, which is that the patient has to suffer from an illness that's terminal in nature. They have to have an advanced state of irreversible decline in capability and suffer from constant and unbearable physical or psychological pain which cannot be relieved in a manner the person deems tolerable. So we have some more details that physicians can use to try and determine whether or not someone qualifies. It doesn't limit the right of healthcare professionals to refuse to participate, but if they refuse, they have to make a referral to the director of the facility, and that director will find someone else to do it. And then there is an oversight mechanism through both the hospital's medical advisory committee as well as a 7-member provincial commission. So Quebec has basically said, and I think this is maybe a lesson for the rest of Canada, Quebec said even after putting the legislation in place, which we haven't done yet in Canada, even after that they said it's going to take us 18 months to put a framework in place. And they're just coming up to that on December the 10th of this year. So they've been really doing a lot of work on this that the rest of Canada has really not started yet. Margot alluded to the recent controversies by palliative care physicians and facilities to take part. This discussion is not over. Nationally, the support in the palliative care community is certainly lower than in the general physician population. And we're hearing very clearly from our palliative care colleagues that most of them want to see a very bright line between that provision of palliative care and assisted dying. So we have to figure out how to make sure that there's a continuity there that doesn't stop because of that. And in Quebec, it does differ from the Supreme Court ruling in that it's euthanasia only. There's a requirement that the patient be at the end of their life, and there's mandatory referral to an administrator. So people ask me all the time, what do you think is going to happen on December 10th in Quebec? And I say, I have no idea, but it will certainly be very illustrative and I think very informative to the rest of Canada to see how that works and how it doesn't. So I'm going to talk a little bit about what we've been doing at the CMA, and I'm going to sort of preface this by saying that you know, attitudes have really shifted in the medical profession over the past few years, and certainly at the CMA, where we've decided actively to take a much more sort of in-depth role in this discussion, recognizing the impact that it will have on the medical profession. And so about 5 or 6 years ago, I went to the board and I said, I'd like to do a survey on assisted dying. We haven't done this at the membership in about 15 or 20 years. And I'd just like to ask them about their views. And the board said, no way, that's way too controversial. You can't talk about death and dying. You know, the press could find out about that, and you know, people could spin it around and say we're in favor of it. And I said, okay, all right. And then you could start to see these cases sort of coming, and the public discourse started a little bit more. So I went back and they said, okay, you can do your survey, but that's all. And so I did that, and we really saw that, as I mentioned, not too much had changed from the physician perspective, a little bit more support. And then Carter, you know, started to work its way through the system. So I went back to the board, which now had changed quite a bit. We had a change in senior management as well, and I said, look, this is coming, and we can either get ahead of it or we can get completely steamrolled by it. It's really your choice. And they said, okay, you're right, we need to get ahead of it. So I said, can you give me like $2 million and I'll go out there and do some really neat stuff? And they said, yeah, all right, okay. So what we did was some really neat stuff. So the politicians have been talking for years. Every time you hear a politician talk about assisted dying, they say, you know, before Carter, oh, this is so complicated and it's so difficult. We really need to ask the public what they think about it. And then there's like crickets in the background. And so none of them did anything about it, right? Because politically, this was dynamite to try and address this within a political cycle. And so we decided this was something we could do. So we organized 5 public town halls, and we started, for reasons I will never understand, in St. John's in February of last year, and then out to Vancouver, Whitehorse, Regina, and Mississauga. And it was moderated by, each one was moderated by a senior editor from Maclean's, and I understand they actually almost came to blows over who got to do the next one because they enjoyed it so much. And then a 3-person panel. And it's important to say that for really the first time in our history, we weren't spending, you know, horrendous amounts of money going around the country to tell people what we thought about that. We're really good. The CMA is excellent at that. Doctors are very good at going around telling people what we think and why they should think the same thing that we do. We were actually very transparently just listening. We didn't want to tell anybody anything. We just wanted to hear what they thought about these issues. And so we had a 3-person panel, which was myself and a local palliative care physician and a local member of the public who had some experience with death and dying in that community. So we really had that sort of local context to what things were like where they lived. And we divided it up into 4 parts. So we talked about terminology, and we've already heard the importance of language here, and we still don't have agreement on that. We came up with some of our terminology. We convinced a bunch of politicians to use it on the floor of the House of Commons. It's in the record there, but still our palliative care colleagues don't like the language that we use, so you can't please everyone. We talked about advanced care planning, palliative care, and medical aid in dying. And we gave equal time to each one of these, because otherwise we knew that the entire conversation would be hijacked by medical aid in dying. We didn't want that to happen. And when we finished the night, people would say, thank goodness you did that, because I'm so glad you made us talk about all the other really important aspects of care at the end of life, because all anyone wants to talk about in the media these days is medical aid in dying. And all these people said, I'm going home tonight and I'm going to talk to my family about what I want done, which is way more important than any of these other conversations that we have, right? It's those conversations that take place between patients or people and their families and their loved ones, so that everyone understands what their values and their wishes are. And one of my colleagues was actually in Vancouver at a coffee shop the day after we had our town hall there, and there were people at tables talking about this town hall and saying, you know, how it opened their eyes, and they went home and had these conversations, and it was incredibly gratifying. It was unlike anything that the CMA had ever done before. And then we released a report, a very well-received report, that summer on Parliament Hill, and we heard that we do need clear terminology. We need to continue to encourage Canadians to discuss end-of-life wishes and prepare advance directives. And we desperately need a national palliative care strategy to make sure that we have access and funding and better education for physicians and other healthcare providers. We do a terrible job at educating doctors right now on palliative care. The average Canadian med school has 3 hours in lectures on pain management. The average Canadian veterinary college has over 100 hours. And no, your grandmother is not a dog, but at least, you know, should have the same amount of knowledge from their healthcare practitioners when it comes to pain and suffering as veterinary medicine folks do. That's a real shame for the medical profession. We also very clearly heard that the Canadian public is divided. And I was talking to Andrew earlier. One of the great things in all this for me has been to see the high level of discourse and the respectfulness of that discourse on this issue that I haven't always seen. And I was at a meeting in Vancouver that was just physicians, and I had the medical director of Dying with Dignity and the medical director of the Anti-Euthanasia Coalition in the room with me, and the conversation could not have been more collegial. You know, well, I understand your point on that. I will respectfully disagree. I feel differently. There was no raised voices. There was no angst or anger. And the same thing with the public dialogue. People were very, very respectful of each other. We also heard that if the law in Canada is changed, then people felt that strict protocols and safeguards are required to protect vulnerable individuals and populations. And I think that's where we're at now to try and figure out what that might look like. We also did an online dialogue with our members, and generally when we do an online dialogue we get about 10 or 20 doctors that sign up. This is a bit of a pain. You got to get a password, you got to go on there and check other messages. We had over 1,200 people register for this one, just completely off the charts for us. Hundreds and hundreds of very thoughtful comments. And then we did an in-person member consultation, and I went around the country and mediated a whole bunch of sessions with members in different locations as well, again, where they lived. And what we heard from our members is that Canadian physicians are ready to lead the conversation, or at least be an active participant, and death and dying are no longer taboo subjects. We clearly recognize the need for advanced care planning and palliative care services, and we are divided on the issue of assisted death. And this all led to our General Council meeting in Ottawa last year, and the key resolution there said that the CMA supports the right of all physicians within the bounds of existing legislation to follow their conscience when deciding whether to provide medical aid in dying. And this was a real change for us. There were a lot of people who thought this was a great thing and a lot of people who thought it was not so great. And so basically what it did was it took our policy from saying these things are illegal and physicians should not participate to saying if things change, if the law changes, we will support our members on both sides of the issue. We made it very clear that this is a societal decision. This is society's prerogative to decide what these laws will look like. And we will not judge our members based on whether they decide to participate or not. So for the 30% who have told us, yes, this is something I feel comfortable doing, we will support their right to do so without discrimination. And conversely, for the 70% who have told us, we don't want to do this, we will support them as well. And I can tell you, we have a fairly small percentage. I alluded earlier to the issue of mandatory referral. A pretty small percentage who have said really very vocally, I do not want to be forced to refer against my wishes. It's probably less than 5% of our members. We have gone to the wall for them to protect their right not to have to refer mandatorily. So we have kept our word that we would support all of our members on this issue. So I'm going to conclude by talking a little bit about sort of where we are now and what some of the next steps are. So what we've done is we've developed what we call a principles-based CMA legislative framework, or a guidance document. We were the first out of the gate with a series of recommendations for what potential laws or regulations could look like from the standpoint of the medical profession. And I will say, this is where I was saying before to Margot, that what the CMA actually has said is for those people who would qualify for it, they must be made aware of the availability of palliative care. So it's just part of the informed consent process, like it is for any type of intervention. You have to make people aware of what other things are available for them. So for someone who's asking about assisted dying, you have to let them know about palliative care and pain and symptom management and pastoral care services and social work and all these other types of things. That's just sort of standard medical practice. Now, when we went to our membership and we asked them, should a palliative care referral, do you think that should be mandatory? They said no. And the reason they said no was because there will be a percentage of patients who won't benefit from palliative care. Because of the way the Supreme Court decision has been framed, there will be people who will have intractable depression who will want access to assisted dying. Putting them in palliative care would not be the right place, right? They should go see a psychiatrist. So we didn't call for mandatory palliative care referrals. We didn't call for mandatory psychiatric evaluations. In fact, what follows is going to be a clinical decision based on the individual circumstances of that case. We've actually been working on this for about 2 years, this framework. So 2 years ago, I hired a summer student, and ever since then, we've been working on this based on other jurisdictions, based on what other medical associations have done, and then based on the Supreme Court decision, as well as a number of milestones with our membership to get their input and feedback. And people have said, oh, wow, that's amazing. Did you have a crystal ball? I said, no, but I have an internet connection. And it was really easy to read things and see where everything was headed. And again, we didn't want to get caught behind all of this. We wanted to be prepared for any eventualities. So this document really is intended to address a number of the unanswered questions and fill in some of the important gaps relevant for physicians. And it's being used basically as a foundational document to present our views to federal and provincial legislators. And here's where I'll sort of diverge from John's view, which is obviously well thought out, that we could sort of do nothing and that things would work themselves out. This is fundamentally different from withdrawing life support, and there's 2 reasons for that. So whatever you think in terms of the moral equivalency of those actions, to physicians, they are almost unrelated. So if I came over here and I took an intubation tube and I put it in your throat, and then I left it there for a few minutes, and then I took it back out, you'd be really angry at me, but you'd be okay. You wouldn't die, right? Because you don't have an underlying condition that's leading to your death, right? So in the situation where I'm removing life support from someone and they're dying, they have an underlying condition that's leading to their death. They're not dying just because I remove life support. They're dying because their whole body has failed, right? In the condition where I come over to you and I insert an intravenous needle and I give you a massive bolus of potassium chloride to stop your heart, doesn't matter if you have an underlying condition or you're healthy, you're going to die. And it's going to be my action that's caused that directly. So again, regardless of how you feel from a philosophical standpoint, the medical profession sees a clear practical distinction between those 2 things and does not want to see those treated as equivalent when it comes to medical practice. And this is why we feel very strongly that we actually do need regulations and legislation in this area to make sure that everyone understands what's at stake and to make sure that there's a clear process that's followed. And the second thing I'll say about that is we are not just talking about the equivalency between assisted dying when someone has a terminal illness and removing life support. We are talking about people who have an illness that will not lead to their death. People who have purely psychological pain and suffering, which is not to minimize in any way psychological pain and suffering, but those people would live for another 20, 30, 40 years if we didn't do anything. And that's very, very different from withdrawing life support for someone who is depending on life support to live. Those things have no comparison in the medical world. And so to sort of treat those as a continuous sort of series of events or being equivalent is not something that the medical profession is in any way willing to do. So we're really looking to provide the views of Canadian physicians on some of these really complex issues, like trying to get a sense of who should qualify, what the process should be, the role of the physician, and the protection of conscience. And I'll just sort of tell you what we're doing at the moment. So before the election, I had meetings and conversations with members of Parliament from all the different major parties, spoke to them about their views. We are in the process of organizing meetings with the Federal Minister of Health and Justice now, and they've both shown an interest in having a lot of conversations about this. We really want to see a unified national approach. So what we had with the therapeutic abortion situation was essentially the Supreme Court ruled that the legislation was unconstitutional. They gave government a year to do something. They let that year go by, and here we are, however many decades later, with nothing on the books. So there's no law in Canada with respect to therapeutic abortion. And what we have instead is a provincial patchwork where your access to abortion might vary depending on which province you live in. And we don't think that would be acceptable for assisted dying. We don't want to see a situation where one province says, well, there's a mandatory 6-month wait between your first request and when you would qualify, and another one says, oh, it's a 2-week wait, right? What's going to happen, people are going to start moving all over, doctors and patients, and it's going to be awful for everyone. So we would really like to see a very unified national approach. And so, again, we're meeting with folks at the federal level on that. Now, failing that, we're a little bit more optimistic these days than we were a couple of months ago, but failing that, we recognize that this is going to fall to the provinces. So the other thing that we're doing, again, for the first time in our history, is we're sending me around the country to meet with all the provincial ministers of health to say, look, do you agree that the federal government should do something about this? If you do, please give Jane Philpott a call. And they all said, yes, they will. But failing this, will you get together and come up with something that's reasonably consistent across provincial jurisdictions? And to our shock, they're all saying yes. Actually, they're saying, we've already been talking about this, and they're having a meeting about it in Vancouver in January, where this will be very prominent on the agenda. So the provinces are actually saying, we understand why we don't want a provincial patchwork. And then there's these two expert advisory panels, the federal one that, as Margot says, sort of had their legs cut out from them a little bit this week, and then the provincial territorial one that was struck by the provinces and territories. And we've met and shared our documents with both those folks. And then we continue to provide ongoing support for our members. And one of the big things that we're doing is we're in the process of trying to organize and plan a major educational initiative, also sort of a new thing for us, where essentially we want to step forward and say, look, we need to provide sort of a national level educational program on this. I've already said this is something brand new for Canadian physicians, not just for the technical aspects of assisted dying, but for all of end-of-life care. So we're planning for a 2 to 3 day in-person course where physicians can come, learn all about end-of-life care, learn as well about assisted dying and the technical aspects, and be proficient at this so patients can feel like the physician that's treating them has some training in this. So that's something that's ongoing as well. And the objective of all of this work, the last 2 years of the work, is to see the views of physicians who will, we know, ultimately be responsible for administering this, reflected clearly in legislation and regulations so that patients who qualify will have access to assisted dying, physician rights will be protected, and potential abuses will be minimized. Thanks very much.